you all know, we gathered you today because we launched a survey that we would like to share our results with you today. And the topic or the name of today's event is Improving Psychiatric Care in NYC Hospital Emergency Rooms. We want to listen to patients and family members from them and their psychiatric emergency room experiences. And we wanted to find out what can be improved within our system in order to make sure that we're best accommodating everyone in our mental health community. So without any further ado, I'm going to introduce myself. My name is Kimberly Blair. I am the Manager of Public Policy and Advocacy here at NAMI-NYC. I use she, her pronouns, and identify as both a peer and a family member. So I'm so happy to introduce my wonderful colleagues. I'm going to begin with Ray, who is also a part of NAMI-NYC. He is our board co-president. He's a highly skilled nonprofit executive and manager with a deep knowledge of current healthcare policy and over 35 years of experience in the mental health field. Welcome, Ray. Would you unmute yourself and say hello?
Good evening, and I'm glad everyone is here. I appreciate you taking the time to attend.
Nice to have you, Ray. Next is going to be Joanne Kennedy. So Joanne Kennedy is a supportive family member and a member of the Board Advocacy Committee of NAMI-NYC. She serves the Manhattan community in her various roles. One of them is as the Catholic worker in the Lower East Side, but she's also the leading organizer for Manhattan Together, along with Michael Stanley, who's also on the call, but he's not a panelist today, but I wanted to give that shout out. And Manhattan Together is an interfaith organization comprised of multiple member congregations throughout the borough of Manhattan. Joanne, please say hello to our guests today.
Good evening, everybody. We're so excited to be here tonight. Thanks.
Love it. Next is John D Natalie. John D Natalie is a supportive family member and member of the NAMI-NYC Board of Directors and the Board Advocacy Committee. He is the Associate Dean for Communications and Public Affairs for Cardozo Law School. He has also served as the head of Cardozo's Communications and Media team since 2010. Welcome, John.
Thank you, Kim. It's great to be here.
Great to have you. Next is Rabbi Lawrence Siebert. Since becoming Town and Village Synagogue's head rabbi in 1991, he has engaged and inspired his congregants to climb the ladder of Jewish commitment. He inspires through his warm personality and non-judgmental style, as well as the power of his intellect and his creative approach to the study and practice of modern conservative Judaism. Rabbi Siebert is also a member of Manhattan Together. Welcome, Rabbi.
Thank you, Kimberly. Thanks for the introduction, and thank you all for being here.
Thank you. Next is Alan Doyle. Dr. Alan Doyle is a member of the Manhattan Together organization as well. He previously served as the Director of Education at Fountain House, a nonprofit organization fighting for the dignity and dreams of people living with serious mental illness in our own New York City. During his time at Fountain House, Dr. Doyle oversaw an international training institute for a community approach to psychiatric recovery. Welcome, Alan.
Thank you very much, Kim. And I'm looking forward to working with everybody who's on tonight on the recommendations that are coming out of this survey.
Thank you. So let me give you an overview of our organization. Some of you are new to our NAMI-NYC community, and we just want to give you an overview of who sponsored this event tonight. Well, first, NAMI-NYC is one of the largest affiliates of NAMI National, which is the National Alliance on Mental Illness. It is the leading grassroots mental health nonprofit organization, and our mission is to help families and individuals affected by mental illness build better lives through education, support, and advocacy. Working with us today and co-sponsoring this event is Manhattan Together. You heard of them. We have some representatives here on the panel, but they are really a citizens and aspiring citizens power organization around the city. They are a multiracial, nonpartisan, and grassroots organization. Their dues-paying membership organizations work together to improve the quality of life in NYC communities. We're so happy to be working with them today and to also introduce to you the list of partners that we really worked with in order to launch this survey. And my colleague Ray is now going to introduce to you these partner organizations.
Good evening again, NAMI-NYC Board Advocacy Committee and Manhattan Together in constructing this project and working to get these surveys completed. We also worked with with a half dozen partners who helped distribute and get people to answer those surveys. And that's B'nai Jeshurun, Central Synagogue, Community Access, Society for the Advancements of Judaism, St. Ignatia, Loyola, Temple Shari Tefillah, and Tannen Village Synagogue. Thank you.
And so we're just going to give you a little bit background and introduce why we did this survey. NAMI-NYC and Manhattan Together, along with all of these partner organizations, launched a survey in 2019 to uncover the experiences of people seeking psychiatric care at emergency rooms across New York City, and to uplift the voices of their accompanying support systems. This includes family, friends, and caregivers. Our goal was to assess strategies that are currently working and areas that still need improvement within the hospital setting. We also had several objectives that now my colleague John is going to talk a little bit more about with you.
Thank you, Kim. And as Kim just said, the survey objective really was to give patients and their families and loved ones a voice at the table. We conducted the survey because at NAMI New York City, we work directly with patients and family members all the time. We teach classes about how to deal with serious mental illness. And from those classes, we hear from hundreds of patients every year and their loved ones about the trauma of intake at the ER. ER intake is critical, but it's incredibly varied from hospital to hospital, and even within an individual hospital, depending on when you arrive. As far as we know, nobody has systematically asked mental health patients and their loved ones for feedback about the ER experience. And that gap in understanding deprives them of a voice in their care. We believe the ER experience and the quality of care of these patients in the ER has a big impact on outcomes. Imagine, if you will, being in a mental crisis, a mental health crisis, and having to wait 24 hours in a hallway where emergencies are coming into the hospital from ambulances. That's not a good way for a good outcome. Would a heart attack patient left in that hallway last that long? No. And yet a mental health crisis is critical, just as a heart attack patient, especially for a patient in the first psychotic break. My own personal experience with a family member has been very varied. Most recently had an extremely positive experience. It was a Manhattan hospital. My loved one was seen by a regular attending physician within 15 minutes of going into the ER. That physician determined that my loved one did need to go into a psychiatric ER, which was a specially equipped area for mental health patients. A psychiatrist there in a private area that was quiet and controlled talked to my loved one for 15 minutes, and then came and talked to me for 20 minutes to gather information from the family about his condition. Contrast that with a different ER at a different time where my loved one was left sitting by a security station where police guards and ambulances were moving people in all throughout the night, including a stab wound patient. And this was for many, many hours. That's not a good intake situation. And a third intake experience we had, my loved one was put into a room with 10 other patients who were all in severe distress. He was there for 48 hours waiting. He was seen at several times during that time by psychiatrists, but most of the time he was only seen by security guards who were looking through plexiglass. He finally said, "Get me out of here. This is a jail." And we realized that we had to get him out there despite the fact that he really needed care. So our goals, as you can see from this slide, on doing the survey, and by the way, I didn't fill out any surveys because that would have been my bias going into it, but our goals were really to use the survey to find out what the experience is like for patients and for their loved ones, both positive and negative, and to give them a voice. Our first real goal was to provide feedback and to create a report so that we could systematically look at the situation and present that to hospitals. Our second goal was to create a campaign to set a standard of care that provides for dignity and respect and that leads to better outcomes for patients, and that helps support communication between healthcare professionals who are in that system and the family and patients themselves. And our third goal was to build partnerships, and we were very fortunate to have partners like Manhattan Together and the other partners who helped us in this, because it really expanded both our knowledge of the problems and our ability to reach a very diverse group. So I'm very happy about that, and we want to continue that. In the next slide, we're going to talk about survey methods. We created two separate surveys. The first survey was for patients themselves to fill out, to give their view of the ER experience, what it's like from their perspective. And that survey included very specific questions, which are, I agree, I disagree, or here's, a simple answer, how long were you asked to wait? It also gave them the opportunity to have an open-ended questions where they could write down what their experience was and what they thought should be improved. The second survey that we did was conducted for family members and for friends and loved ones who accompany patients to the ER. As witnesses to the hospital ER experience, they have valuable information to contribute, and as people who know their loved ones. At NAMI New York City, we know that very often family and loved ones have critical input about their loved one's condition and their immediate needs, but very often that information is not relayed to the right person at the right time and to the doctor who's actually making treatment decisions. So we conducted the two surveys because both groups have valuable insight. What are the needs of the patients? What would improve the ER experience? What causes unnecessary tension and stress that could worsen the chances of recovery for patients? And what insight can we glean from the results to improve? We use both electronic surveys and printed surveys. We ran the survey from September 2019 until January 2020, and we did it in English translation, Spanish, and Chinese. We had the data assessed by an outside consultant who's familiar with survey procedures and best practices. And we also conducted several interviews with psychiatric ERs in the process of creating the survey to make sure that we were asking the right questions and getting input from people who are actually on the caregiving end. In the next slide, we will talk just briefly, just so you have an idea of the patient's response. We had 60 participants in the patient response. And we also asked them for information about gender, race, and ethnicity, so we could see if the groups of people who were having different experiences, if these different groups of people were having different experiences in the ER. And we hope to keep doing some of these surveys to be able to look over time to see if there's any trends, to see if there's any variance in care, so that we can help ensure equity of patients from all backgrounds. And now my colleague, Joanne, is going to talk about the Friends and Family Survey.
Yeah, so the Friends and Family Survey was basically, the point was to get the experiences. If people didn't want to fill out the survey themselves, we know that families have a lot of feedback as well. So they go in partnership along with the patient consumer survey. So just real quick, the details were that we got 64 of these surveys. And everybody was over 18 years old. To the gender question, we had not as many respondents. We don't really know why. It's an interesting thing to follow up on, but it was mostly female that did respond. And then the race and ethnicity questions, which we added later. So there were a couple people who saw the survey and didn't get that question, we got mostly white respondents. And we knew that that was going to be a weakness of the survey because the survey sample that we had was still small. And then we got kind of shut down by COVID. We wanted to do more and broader, but hospitals were very busy. And this is a pie chart just to give an idea of the hospitals that people reported about. You know, we did not go into it asking, did you go to this hospital or that hospital? We just said, have you been to any emergency, whether or not it has a Psych ER or not? And these are the hospitals. So it's a good range, right? You see the major hospital systems of New York are on there: Presbyterian, Mount Sinai, New York Health and Hospitals. And it's pretty spread out. It's a lot of Manhattan hospitals, but it's a lot of different ones from inside Manhattan. And now Ray.
As you might guess, all surveys have some limitations, and ours are no exception. One major area that limited our survey was, in fact, as Joanne noted, the COVID pandemic, which really put her in a difficult position of getting questionnaires answered and sending them out. Also, our sample size was not as large as we had hoped, and we do have an overrepresentation of Manhattan hospitals, and we did not initially get as much demographic information as we would have appreciated and in retrospect needed. So we will certainly consider continuing the survey in some date, but we really wanted to get some of this information out so we can begin to engage with more people about what we have found. And the next survey slide will tell us a little bit about a major theme that I think was evident from the surveys that consumers, patients completed, where family members were able to remain with the individuals reported better outcomes. And I think that's not a big surprise. Staff gave them more emotional support, more respect. They would recommend the hospital. They were engaged in the care decisions, and they felt their confidentiality was protected. Additional major themes, which will show up in the next slide, are also important to consider. Again, no big surprise: shorter wait times, better overall positive experience. And also shorter wait times increase the likelihood that that the individual, the patient, consumer would recommend the ER. Kim?
Sorry, I had to unmute myself. Theme of this pandemic. Thank you so much, Ray. And so basically we have here that also a major theme was that shorter wait times, so less than 30 minutes, were associated with an overall positive experience in the ER. Shorter wait times also increase the likelihood that the patient would recommend the ER to others. So we can deduce from that that shorter wait times just seem to be associated with positive experiences that folks want to share with others, and then recommend maybe that hospital to others. So here we have a quote. And it says, "I walked in because it's the best facility in the city. Even though I should have used an ambulance, I wanted control over my care quality." And so we don't want to add our own, we can only hypothesize when we read these quotes out what the intentions were when this person wrote this. But these are quotes taken directly from respondents to our patient survey. And it seems that while many folks would think that people who walk into a facility are voluntary, it wasn't the case for everyone who actually responded. Some folks walked in and we don't know why they answered that it wasn't a voluntary experience for them to come into the Psych ER, but this specific person here felt that walking into a facility was the only way they can control what hospital they could have been receiving care from, because we all do know that the ambulance takes you to the closest or nearest hospital. Maybe that nearest hospital that the ambulance would have taken that person to was not the care that they thought that they deserved. And this is what we hypothesized from this. And now I'm going to pass it over to Ray.
Another patient survey major theme was regarding those who were not admitted to the hospital, who said that they were not given information or referrals for follow-up care. That's really important for us to acknowledge and figure out how to respond to and work with hospitals to continue to improve in that area. Another major theme in the survey, next slide, please, was of those who did receive referral information, 55% said the information was not helpful. Well, that's not any better than not getting any information. And only 16% said it was helpful. This is important. This is disturbing. And we need to figure out why so little referral and information was provided. Alan.
Thank you, Ray. In a similar vein regarding information, when patients were asked whether hospital staff had told them of their privacy rights, the majority of the patients, 59%, indicated that they were not apprised of their privacy rights. Additionally, when patients were asked, in the next slide, please. When patients were asked in the survey whether they were treated with respect by their doctors, nurses, and other ER staff, 23% of the respondents indicated that they were either disagreed or strongly disagreed that they were treated with respect by the ER staff. However, 2 patient respondents did explicitly mention that their treatment was mixed, with some staff, namely the nurses, treating them better than example. The next slide, please. One patient reported.
Sorry, Alan, one moment. I think there's a little static on your side with the mic.
How is that?
Much better.
Okay.
Thank you.
Do you want me to go back?
Here, yeah, let's go back. Thank you.
Okay. Regarding the first piece of information that's given to individuals as they enter, or the patients as they enter an ER, patients were asked whether hospital staff had told them of their privacy rights. And the majority of the patients, 59%, indicated that they were not apprised of their privacy rights. And additionally, when patients were asked in the survey whether they were treated with respect by their doctors, nurses, and other ER staff, 23% of respondents indicated that they either disagreed or strongly disagreed that they were treated with respect by the ER staff. However, 2 patient respondents did explicitly mention that their treatment was mixed, with some staff, namely the nurses, treating them better than other staff. For example, and for the next slide. For example, one patient reported the nurses were wonderful. Adding in contrast, however, The psychiatrist who interviewed me wasn't competent and did not listen.
So we asked the family and friends survey the same question about respect. And one of the things that we discovered is that family and friends overall felt more respected. And as somebody who has accompanied friends and loved ones to the Psych ER or just to a regular ER in the midst of a psychiatric emergency, I think that that sometimes happens, that sometimes the staff goes to the family and doesn't give the patient or consumer as much respect. So that's an issue. That's something for us to discuss among hospital staff and talk about how it's very important that everybody in the mix feels respected. But even though a few more family members felt respected, it was still pretty poor. It was only about 34%. Right. I shouldn't say that. A majority felt respected, but only 34% still thought that they would recommend that hospital psychiatric ER to other people. So even when you felt sort of respected, it still wasn't a great experience. Imagine if this was something else like a restaurant and only 34% of the people who went there thought you should go back, like you wouldn't go back. This is not a very good, claim for how good our hospital ERs are in the city, even the ones that are fairly respectful. So we also looked at the surveys to sort of pluck out major themes in the kinds of answers we got. So one of the major themes from the Friends and Family survey was that nearly half of the respondents said they had to wait for more than an hour or up to an hour in order just to be assessed. So this is not waiting for an hour to talk to a psychiatrist. This is waiting for an hour to check in, explain what's going on, and figure out what the next step is going to be. So this is a major burden on people who are coming in for this kind of help. An hour of sitting around waiting is a terrible strain. So Rabbi Larry's got the next slide.
Oh, Rabbi, you have to unmute yourself.
Clearly, people are frustrated by the amount of time they have to wait to be seen in the ER, but the vast majority of folks who do come to the ER for psychiatric illnesses are there voluntarily. So we want to create the kind of atmosphere, the kind of space that will make it easier for people to come to the ER, with 80% of walk-ins patients come voluntarily, and 64% who ride by ambulance are there voluntarily, meaning that they or a family member had called the ambulance to bring them in. And a significant number made comments about the size of the ER, the fact that there's not enough room, there's the extensive time that they spend in the hallway, the need to transfer locations to access a bed. One person mentioned that she was kept on a gurney in the hallway of the Psych ER, surrounded by other patients, being watched by security with fluorescent lights for 3 nights and 2 days. Clearly, this can only exacerbate the issues that bring people into the ER in the first place. This is not. One of the things is that within the general context of the ERs, we do know that there are long waits in ERs, for whatever reason you come to the ER, but it's much more critical that attention be paid to the Psych ER because of the fact that the treatment of patients who come in will have the potential to make things worse because of anxiety that is generated as a result of a lot of waiting and in unpleasant conditions.
And so we have here a quote from a respondent illustrating, thank you, Rabbi, illustrating what Rabbi was talking about. It says, past experiences have been good, but the fact that this time she was sent far away was horrible. Round trip commute for us was 5 hours, 2.5 hour trip each way. This speaks a lot to the work that we do with the ambassadors here at NAMI-NYC in our policy agenda. One of our big topics is indeed this issue that there is a consolidation of psychiatric hospitals around the state and cuts to psych beds, which has always been a problem, but was exacerbated during the COVID-19 pandemic. And thus, when people need a bed, they don't have one, and they have to be transferred upstate, far away from their social networks and support systems. Imagine how you would feel. Put yourself into this person's shoes, in this respondent's shoes, as a family member, wanting to support your loved one in the Psych ER, and it being just so far away. And now I'm going to turn it over to John to talk a little bit about other comments.
So other comments from family and the family and friends survey, not the patient survey, not surprisingly, they found some of the same concerns. A lack of privacy was one of the first things they talked about. That makes it very hard for a patient in psychiatric distress to talk about their condition, to feel comfortable talking with new people, whether it's a psychiatric nurse or a social worker, or there are other people in the ER who just come by to make sure everybody's okay, who don't have any psychiatric training in how to talk about these issues. And so the lack of privacy was noticeable among the family members. Waiting for long periods of time in hallways is a consistent problem. And as Rabbi Siebert said, lots and lots of different patients wait in hallways. It's a particularly big problem for somebody who's having a psychiatric breakdown. Waiting to be seen by health providers who could actually provide treatment, and the conditions in general, and that included noise, confusion, lots of stimulation, and lots of people coming into the ER and sort of the continuous change of personnel in the ER is a big problem. I would note that when we were interviewing the psychiatrists to help us formulate the questions, one of the things they talked about was the intake at the ER and how it would be a lot better from the psychiatrist point of view if they knew if they had a place for the more serious patients to be, so that they knew where they were walking, what they were walking into, and to sort of have a different room for patients who just needed a medical check, who just needed to get back on their meds. But that just indicated to us that there's a lack of coordination within hospital units about this. The next slide, we asked patients about the time spent during intake. This is the time that Joanne was referring to before they're actually taken into the ER, before they're actually seen by a psychiatrist. Over 50% of patients said they waited between 30 minutes and 3 hours just to see somebody who could talk about their situation, just to see, even if it was a psychiatric ER nurse who could help them evaluate what they needed. These are often patients who are going in for serious mental distress and whose condition will worsen the longer they're not treated. And as you can see, some of the wait times were quite longer for significant numbers of people, 3 hours or more for up to almost 18% of people. The next slide is showing the total time spent in the ER, and it is also pretty troubling. Over 20% of people visiting the ER with serious mental health crisis were held for between 12 hours and 1 full day. And some percentage of patients, significant percentage of patients waited considerably longer than that. This wait time is often related to the number of beds available in psychiatric wards. There is a serious shortage of beds, and people we spoke to in the ER said that that is a problem. This puts enormous pressure on the ER staff because they have to hold patients much longer than they should, and they know that. It stresses the ER, so it's bad for them. It's bad for conditions in the ER, and it's critically bad for patients who are in the midst of trying to struggle with either a serious suicidal depression or psychiatric disorders such as paranoia. Getting them treatment, getting them medication is delayed while this doesn't happen, and it's because of the lack of hospital beds. This is a system that has reduced hospital beds, and this is not in the survey, but this is well known for these critical patients. And that's that's something that can't be neglected when you talk about the conditions in the ER room for psychiatric patients, because that's what's putting pressure on keeping people in these rooms, in these ER rooms so long. I think that's it. Number of people interviewed in the survey questions complained about the shortage of beds and the intense pressure. And so I think we've covered that.
Thanks,
Sure.
John. I think it's my turn now.
Yes,
Sorry,
it
it's Joanne. So yeah, I just wanted, that was great, John. I just want to add that, you know, what we did, we asked people for what was wrong. And then we also asked people for what they would suggest, because who better to suggest what we can change than people who have lived through it, right? So what this slide is about, suggestions that the people who took the Friends and Family Survey offered about things that could do, that hospitals could do to make the experience less traumatic for everybody. And so it's not a surprise, people thought privacy would be better, no more waiting in hallways, right? And also that it seems obvious that maybe the waiting areas need to be larger, right? So the size and the atmosphere of the physical waiting rooms has a big impact on people's experience of the whole thing. So that was part of it. And then about 20% suggested that, you know, an increased level of training among staff might help them better understand what's going on with patients and family members when they come in. And that would increase the level of compassion and respect that the staff might have for what people are going through. And I just want to add that I feel like we know which hospitals in our city compete for being the best place to go if you have a heart attack or if you have a brain tumor. Imagine a city where we knew which was the best hospital to go to if you were having a crisis of your mental health. Like, I wish the hospitals would compete for being the best hospital for taking care of mental health. And I feel like we can ask the hospitals to do that, right?
Definitely, we should be asking that from hospitals. And now I'm going to move on to a quote that really illustrates what families go through. You know, we had one respondent that said, allow a family, I mean, they told us, they gave us the answer, allow a family member to stay with the client until they are admitted. Don't put the client in a secluded room, fully explain what is expected. Have a peer specialist speak with the client and try to help the client be less nervous. Have the social worker speak to the person's family or friends and give them contact numbers so that they can contact someone to inquire about their loved one's progress. Most times, the client is scared and terrified of their experience. I don't think I need to even add anything to that. It really speaks to them for itself. We need more peers. That's what this whole organization is about. We need to uplift peers into various roles, and we need to make sure that peer specialists are at the table at every emergency room. Because unless you yourself have gone through a crisis, you will never know what someone in the psych ER is going through. And I feel like that's why peer specialists are so invaluable, and could really bring, can really improve the quality of the whole hospital experience.
Thank you, Kimberly, because families and friends can also provide important insights during this time. And and a family member had this to say in response to this question of how it could be improved, the experience of the ER could be improved. Here, family and friends in the ER are both vulnerable and impressionable, as well as uninformed and overwhelmed. This is a time, however, and a place for providing psychoeducation. The respondent continued and provided a cogent reason for their role in this process and asked for their inclusion as a real member of a treatment team. Quote, relapse rates are reduced by over half when families are equipped to be effective members of the treatment team. And Rabbi Siebert, I think you have the next quote.
And what we see is that even where family members are there trying to help out, that often the hospital staff will ignores their input, and critical information that about the patient, they're not allowed to give that kind of immediate feedback, which would be extremely helpful in moving things forward in a positive way.
And now we're going to really, we talked about this survey. We talked about what were people's experiences in the Psych ER, but Ray is really going to talk about what are the recommendations that we can do and give moving forward in order to really change our mental health care system and improve the quality of the Psych ER. Ray?
Thank you. And I know this survey is really a starting point for us, and we need to think about what we do next and how we can improve people's experience in the healthcare world, specifically when they have the need for psychiatric services, especially in an emergency situation. And we have a list of things that we want to suggest, recommend. The first slide lays out some of them, and you can guess that some of these are already been identified. Reduce the time for triage, evaluation, admission. Are there not ways to make that happen more quickly so that people can be treated and responded to more effectively and more rapidly, which reduces the nature of the crisis? Staff and hospitals certainly can benefit by having specific skills and training to respond to psychiatric emergencies, even those, and especially those who are not in the Psych ER themselves, although Psych ER staff could also benefit by training. And specifically, as we've noted, have space, locations that can be more sensitive and more directly meeting the needs of the individuals waiting for evaluation. And evaluations that happen quickly would also be really important. The alternatives to Psych ERs is something we need to think about, and that's a real policy discussion, which many organizations are pushing. So we know we need to think about how to develop non-hospital crisis services. They do exist. They are existing in a few places in New York State and a number of other places where people can go to and get the services they need without going to an emergency room in a hospital. And certainly these opportunities are being pursued by a number of groups, including Manhattan Together and NAMI and a number of others. So that's really part of the public policy agenda that we need to expand and develop. And then also making sure, as the hospitals need to be pushed and prodded not to reduce beds, not to consolidate their psych bed services, their inpatient services, so that people in need can continue to access them within their community and neighborhood. And this is a real public policy issue. It's a state health department issue. It is a governor's issue as well. But there's more. There's more to be done here. And the New York State has a special category to certify peer specialists who can be really helpful in expanding services and being sensitive to people's needs when in a crisis. And they have a real skill and ability and training and knowledge that is really important, not only in the hospitals, but in a whole range of the services in the mental health world. We also need to acknowledge and remember that families and friends know a lot and can be really helpful. And NAMI trains and provides education to so many people in this area. John is one of those teachers. So if you want to learn more, we have those opportunities, but family members are part of someone's support system. And how do we make sure that information is available for people when they leave the ER? Are there good, is the ER providing really good connection, or just giving a piece of paper and saying, goodbye, you're on your way? What more can be done? When we talk about expand citywide access to non-hospital crisis services, part of that is also making mental health clinics more accessible, available, and easy to access. Part of the fears and discrimination against mental health services is real, and we can help with making those services more comfortable if, in fact, neighborhoods have much better access to walk-in mental health clinics. Part of also is the crisis, a good crisis structure will make sure there are community-run respite centers where someone who knows they are struggling can spend a week in a center where they can be supported in a non-medical way, where peers, specialists are available, and they can decompress and become more acclimated to what they need to do and think about their recovery. Another area which is often neglected is what's called the Psychiatric Advance Directive. This provides the opportunity for a person, the individual, to construct a plan on how they want to be treated if, in fact, they need to go into a hospital and are unable to communicate. This is really something that is often neglected. If you want more information on this, use your internet browsers, do Psychiatric Advance Directives, New York State, and you will come up with a number of different opportunities to learn about that. And NAMI actually has a whole page in there, which will show up, that would help you understand how to walk your way through constructing the Psychiatric Advance Directives. So Kim, I think we're ready for questions, and a lot of questions. I don't know how many answers we'll come up with, but I know there are a lot of questions.
Well, we are going to try our best. Thank you so much to Ray and to all the panelists. If I can get some reaction buttons in the chat for all of their hard work. We also have many other members of the Board Advocacy Committee that have been working behind the scenes and doing their best job in putting this presentation for you all and launching the survey. So thank you to all members of the Board Advocacy Committee as well. So let's get going. I saw so many questions in the chat. Let's see what are a few ones that I can bring to you all panelists now. So the first one we have is, why do ERs combine people experiencing different kinds of emotional distress together in close proximity? Does anyone want to take that on? I have thoughts, but I don't want to go on a rabbit hole here.
I think some of the answers to that are, in fact, space, is in fact staff, is in fact perhaps not assessing people quickly enough to know what their needs are and how to respond to them. There may be other answers to that, but that's what I think we've learned from this survey as one way to understand this.
Yeah, and it's a good question that really deserves an answer from the hospitals themselves, because it isn't always clear. In the case that I mentioned, where you have 10 people with very different but very severe mental and emotional illness going on, it's not a good idea. It's common sense that it's not a good idea to have them all in the same place, where all of that energy is interacting with your loved one or with each other. So it is a worthwhile question. I don't know the answer to it.
Thank you. Thank you. I'm going to keep going because there's actually a lot of questions. The next question, and I'm going to give a shout out to my advocacy ambassadors who are here. For those of you who don't know, I'm going to do a shameless plug. NAMI-NYC has an advocacy ambassador program where you get to share your stories and lived experience with elected officials at the city level and the state level. And to my knowledge, we have 3 right now on the call: Gina Anderson, Lindsay Paul, and Robin Finkelstein. So our next question, and if you want to become a NAMI ambassador, you can go to our website at naminyc.org/advocacy and apply there. So our next question is from Ambassador Gina Anderson. Thanks for doing these surveys. Excellent work. Can you expand on alternatives such as respite centers to Psych Ers?
I can start off, and I'm sure some others will have additional information. In New York City, there are in each borough 1 or 2 crisis respite houses where an individual can apply to be admitted when they're feeling and experiencing real difficulties in maintaining their current residence. And these are places where someone can spend up to 2 weeks working through the struggle they are currently experiencing and be supported by peers and other individuals who have lived experience in this area. These are not, there are no clinical services. There is no obligation to remain for 2 weeks. Some people show up or apply for admission and will spend a day, and some might spend up to 2 weeks, and then you can return to your own residence. It is, without cost. So it is an opportunity to take advantage of a place that might provide support and help in thinking through what's causing the current distress and how to resolve it. I know people who have taken advantage of these respite services, and almost all of them found it extremely helpful.
Is there anybody, I don't think there's anybody here from Community Access on the panel, but Community Access runs one in Manhattan, which is very well respected, but it's very small. And these things cost money. The city hasn't invested a lot in these respite centers, and I don't think there are many beds available. But it would be one way to reduce the stress in the ER if people knew that they could go there. I don't know if there's anybody else on the panel who's had that experience.
Joanne has a hand up.
Yeah, I'll jump in on that, John. I just want to say that you're 100% right, that there hasn't been a commitment to this alternative. And even though Community Access's respite center is considered small, it's the largest. Like, that's the problem, right? So that even, yeah, it's only like 6 or 8 beds. It's really amazing what they do there. That's a good size for a respite center for the services that they do. And it's really great. I really recommend anybody who's interested to go check that out. They're amazing, the work that they do there, but the city hasn't doubled down. They're not really serious about making this a real alternative or using space that they might have and letting contractors use city-owned space to create it. So I think that the respite is something that's like deeply underexplored and a really ready, fairly easy option to improve the situation.
Thank you. And sorry for the abrupt stop share. I just really want us to, see each other and talk to each other and make it a little more homey. So I also see another question from another ambassador, Ashley Lugo. And I think I might actually want to unmute you because I want to ask you to specify what you mean by this. Your question is, has there been any funding or assistance from Thrive NYC? I'm going to allow you to talk, Ashley. Do you mean funding or assistance to help with non-emergency services? Is that what you mean?
Yeah, so I mean, specifically, I guess many of us out there have wondered where exactly the funds have gone for Thrive NYC. I know that when we asked to see financials, we've been told that the money was given to organizations and the organizations did not track that funding. But I mean, we all know that if you receive funding from the city, there are deliverables and you kind of have to track that where that money goes. So I guess my question is, well, not I guess, my question is, are we receiving any, are NYC hospitals receiving any funding from Thrive NYC, not just for emergency rooms, but after a patient leaves with continuing help or anything, any assistance they might need, any programs that they know of or anything like that?
I'm not
Did that
aware of
did that clarify?
anything. Yeah, I'm not aware of
Okay, great.
anything specific that is any funding, any specific funding to provide follow-up services through Thrive for hospitals. I do know that if someone's admitted under certain circumstances in some psychiatric ERs, there is a requirement from the state to follow up or provide some connection. But I'm not aware of anything specific from Thrive. Someone else might be, I'm just not.
Thank you so much, Ashley, for asking that question. Okay, so this question is a little for our folks who maybe never have experienced the Psych ER and want to know a little bit more about the experience. So we talked about this a little bit in earlier slides, but can one of the panelists really talk and delve into how quickly triage is done upon entry? I know the answer is that it varies, but from your lived experiences, what exactly have you all experienced?
It varies, as we know. My own experience in working in Queens at a clubhouse and having members of the program end up going through Psych ERs, it depends on who's accompanying them. Is there a family, is a friend, a professional? Are they brought in by ambulance? Are the police bringing them in? Are they coming in by themselves? And are they able to articulate what's going on? And, and then what's, are they African American? Are they Latino? What else is, all the pieces that might create a different approach to each person are there. And I don't have any, simple answer. I wish someone else does.
I think
Yeah, and I think, go ahead.
I think my experience at Fountain House was similar in the sense that when I take members to a hospital on an emergency basis, we were split up. I wasn't allowed to observe it. I think that's the real problem, that I was only used to help when they transported the individual to the hospital that they were actually going to be staying in. And at that point, it became clear that they needed me because I knew the member, and also they realized that the member would not act out in the same way when I was there, because we understood each other and we respected each other. So I think that really, the question really gets at the real problem is we don't really see what triage is like.
Good point.
Thank you so much for answering that. And so the next question is from Angela Travis. Angela Travis, I'm going to read verbatim because I feel like it's necessary. Is there any discussion about when a person is released? It seems that the policy is to give the person a Metro card and told good luck. Anyone would like to take that on?
That's And that's often the impression that many of us have. I don't know about others.
Yeah, I mean, I've talked to people in the ER who work there who, because I've been there as a family member to bring my family member home, and they always express an appreciation that there's someone from the family here, because a lot of times there's no one from the family. And I think that's what happens, that the person gets released on their own. And that's especially if they're not getting referrals for care. It would really be good if somebody could be assigned to that person who they trust, who they could help navigate the transition, because the transition coming out of an ER setting is hard. I don't know. There are a few people on our, not on the panel, but members of NAMI who are also on this group who might want to say something, who have had different experiences.
I mean, I certainly experienced or observed that very similar. If someone was there to help and facilitate the discharge from the ER, it was always better, more respectful, more thoughtful, and more professional.
I just want to say that I think it all depends a lot too on whether you get admitted or not. So if you don't go upstairs to the hospital, if you just get processed through the ER, I know that at a couple of shelters that I have been at and been around, it's very common for people to like show up at a men's shelter and they'll ask you which hospital you were at, and like, this is your total referral. And not just, that's for medical issues too, but even for psychiatric issues, they're just like, go to this shelter and talk to their social worker. And the shelters are not, they have their hands full. They're not necessarily ready for somebody who's struggling with stability at the moment. So I think this is all part of the like sort of revolving door problem that comes from it also.
Thank you. And I'm going to I typed this answer in the Q&A, but I just want to make sure that everybody knows, because I feel like a lot of folks will ask this question. So will the recording and slides to today's webinar be shared? Yes, we have. If you're registered for the event, you will receive the slides and recording in a follow-up email, but we also record all NAMI public education events on our, you'll see it come up later this week on the NAMI-NYC YouTube channel, and we're on Facebook Live right now, so it'll stay on our Facebook page. So I just wanted to make sure that we answered that. And now I am going to actually read out Larry Live's question. How do we educate the public of what to do when a friend or family member has a mental health crisis? It's hard to know where to turn. You get different answers depending on whom you talk to. We lay people are in the dark until we are forced to navigate this extremely complicated, dysfunctional system. So how do we educate the public on what to do if someone has a mental health crisis? John?
Well, that's one of the dilemmas that NAMI and places like Fountain House are trying to work with right now. I think one of the big things has been the stigma in the society to even talk about mental illness. And I think more and more people are realizing that this is a problem that everybody shares and everybody needs to talk about. There's no simple answer, but I think it's a very important thing that we need to be educating people. I think especially when people are going in the transition from high school to college, there should be a lot of information available to parents about what are the signs to look for, because that's the time when people start to experience serious mental illness. That's when the brain is developing, and that's when schizophrenia can often come into play. But the other thing I would say is, since we're really talking about hospitals and ERs, it's incumbent on hospitals to really try to use their role in the community to educate the public. When people leave the hospital, family members leave the hospital without any information. They should be given information about NAMI, for example. And I'll do a plug for NAMI. NAMI-NYC does psychoeducation classes all the time. It took me and my wife years to learn that this was available to us. Even though we were going into psychiatric hospitals and psychiatric wards, nobody said, you should get your bodies into NAMI and see if a support group would help you and see about education. It's a very good question. And there's a big discussion to be had about that. It's probably its own panel.
Thank you so much for that perspective, John. And I just want to quickly add before we go on to Alan, that all of our classes and support groups, and we just put a link in the chat for those of you who would like to access and learn more. All of our classes and support groups are held free of charge. So, and our helpline as well, it's 212-684-3264. We can also put that in the chat. All of our services are free of charge, so everybody can access here. And Alan, you wanted to add something?
Yeah, I think this is a great question because it shows the dilemma that families really face when their loved one is having a psychiatric incident. And that is, who do they call? The only thing our government gives us right now is you have to call the police. And I think this is really unfair. Personally, I feel this is very unfair to the police. It shows that as a community, we have really given up on how to provide services for people who are in really serious psychic need. And we've left it up to the police department to sort of figure this issue out. This is not to be confused with defund the police or anything, but there are serious proposals now on the table. I think that it was an issue that was brought before most of the Democratic candidates who are running for office, who are running now, they've been selected. But almost every candidate, except the one that won, said we must continue the police as the first responders for psychiatric incidents. And I think that we have a political question on the table right now, that there's information available on alternatives to police that includes the police department when it's necessary. And I think that once the election happens in November, that this should be a serious question for the public. We bring to the public to try to do something about it in a fair way. I don't want to really attack the police on this issue. I think we as a community have given up our responsibility in this area.
Another aspect here is that's also that will change how mental health crisis calls are handled is the new 988 number, which the federal government passed and which will become available after July of 2022. And that 988 number will be specifically designed to help people in a mental health crisis, also folks with an addiction crisis, and will be designed with responders on the call takers who can help navigate some of this. And that ties into what Alan was talking about, the need to develop non-police crisis response structures so that 99% of those mental health crisis calls can be responded to by a peer and an EMT, for instance, and they can respond to it. There are models like that in a number of cities, and some cities have had this going on for many years, and the police are quite happy not to be involved.
Thank you. Thank you.
And there is legislation in New York State working on this, and there are several groups in New York City working on this. One is called Correct Crisis Intervention, NYC.
Thank you.
Yes, and Caitlin, if you could please, Caitlin's our wonderful advocacy intern. If you could please put in the chat the link for CCIT NYC proposal so that folks know what a peer-led response could look like to mental health crises calls. That would be great. So great. This is, I love where we're heading here. We're unpacking so much. And so this is not a question, but I think since we're already on the topic of 988, as well as, the crisis intervention training and what that looks like for police. I have one question. Well, it's not a question, it's a comment, that NAMI Chicago has done public education with the police. And, you know, it's not the answer, but it's a start. Ray, would you like to talk a little bit about like CIT training? I know we have done training of the police to be able to interact with people in mental distress, but we haven't really seen positive outcomes at the city level, at least.
There was a particular program called Crisis Intervention Training that was rolled out, 8-9 years ago, to train police officers in understanding what someone who's going through a mental health crisis is experiencing, provide knowledge and skills to help manage that crisis with that person, and make sure that it can be handled in a way that doesn't require the usual police response, a criminal justice response. About half of the police force was trained, and then about 6 months ago, if I remember correctly, the training was abandoned by the current police commissioner. So that's no longer taking place. And so I think the issue continues to be, how do we construct and fund non-police mobile crisis teams in New York City?
Thank you for that back.
Not a particular, it's a real struggle, but it can be done. Other places have done it. Other large cities have done it and are doing it.
Thank you so much for that background. I just wanted to make sure that some folks knew that we have tried in this area, and also it's not like mandatory for all. So people opt in the police force. So we haven't really seen some of the outcomes. That's why we really want to talk about a whole different system with 988 instead of 911, so that the police are removed from the mental health response, because they don't need a public, you don't need a public safety response when someone is in mental health crisis. You need a public health response. Okay, awesome. So I'm gonna keep going with questions. I see a lot of questions. The next one I have is, what is the experience for people experiencing homelessness? Joanne went into this a little bit, but I guess folks really want to know, especially after being discharged. You know, there's no universal experience. I just want to caution that. So even the quotes we put up, like it is the experience of many, but not necessarily a universal experience, right? So there are some people that have positive experiences, but this question specifically is, you know, they want to hear some stories about folks who have been experiencing homelessness, and what does that look like after being discharged? Panelists?
I'll take it, Kim. So in my, when I'm not working for NAMI, I work at a place that serves people who are homeless here in the city. And we actually see what some people now refer to as street homeless people. So that's people who actually don't even live in shelters. But in this city, people who live in shelters are still considered homeless because that's temporary housing. And I will say that I have met people who have been able to go from a hospital ER to the respite center. And that has been a great help to them. And that's another reason why I think expanding respite is so important, because even if hospitalization is not appropriate for you, the idea of going back to a shelter is very challenging. And respite beds are a great bridge in between. And the respite staff at Community Access's Respite Center are really great about helping people to, you know, just get back on balance a little bit. And then a lot of times they still can return to their shelter and proceed with the approach to finding housing. For people who are not housed, for people who are living on the street, it's much more challenging. And of course, the threshold for hospitalization is still very difficult. So I've seen people ask to stay in the hospital for psychiatric reasons and been refused. So it's not just a question of whether you are, if someone doesn't want to be hospitalized and they're not considered a danger to themselves or society, and they're allowed to go free. But some people come in and say, I'm scared, I am having hallucinations, I do not want to go back out onto the street. And the hospital says no. So this is a terrible problem if people come in seeking assistance and then they're refused. And I think that's about insurance and, like a wrong setting of priorities. So can be very terrible to have a serious and significant mental health issue and be homeless. And of course, it's a vicious cycle. Sometimes the serious and significant mental health crisis has been untreated and has resulted in homelessness also. So it's a vicious circle.
I think, well, first of all, thanks, Joanne, for bringing your perspective and bringing your whole self, talking about your work with the Catholic worker as well. Thank you for your invaluable work there. So I have one question, and this one hits a little home for me because I have some ambassadors that have experienced, they're survivors of sexual assault as well as peers. And so I think that I really want to ask this question and see what your take is. Okay, we might not have an answer, but we're going to try. So the question is, why do psych ERs combine genders together, potentially putting more vulnerable people in danger? Security is not always alert enough if a large male wanted to attack a smaller female. I would also like to ask for folks to just speak a little slower for the interpreters.
Yeah,
I don't know. Go ahead.
Go, John, please.
Yeah, I don't really know the answer to that. I was going to say, I think the idea of separating out different populations in the ER, it seems like they don't do that in any particular group. So, but I don't know.
I think, and I agree, when it's not clear why, except I think we have some indication from some of the respondents to the survey about small rooms, not an inadequate space, not enough privacy, staffing shortages. So I think, that's part of that mix. It indicates a certain lack of sensitivity to individuals who are showing up in crisis and what their needs are. And I think that is one of those real struggles that we need to acknowledge and put out there. People come in with real challenges and really feeling distressed for a number of reasons. And how are we responding to them? How are the ERs really providing that setting and really providing that support? We have some of those answers in these surveys.
Kimberly, I'll just hop in, and I'm sorry, it's probably me who's talking too fast for the translators. I'm sorry.
But it's all of us.
But
it's a Me Too moment for all of us.
That's right. We're all too fast. And I know our time's running down, but I think that the issue that this question raises is about the environment in emergency departments. And that I think particularly around mental health emergencies, it's an afterthought, right? They're not designing emergency departments for this kind of issue. It's just like, well, we'll stick them over there in that corner, or we'll use those 3 back rooms or whatever. So, right, if there can be a more intentional approach to a sort of wide spectrum of care, so people can feel safe in the space they're in, so people can say, I don't feel safe here. Can you help me get to a safer space in the emergency department? This is what, changes everything.
Yeah, and I would also say that's a really good point, Joanne. And I think if there were more psychiatric social workers or peer advocates in ERs, they would be, what's missing from the equation is somebody that the patient can trust and talk to. Very often the patient sees a series of people who ask a bunch of questions, who come in at weird times. You know, they're sitting there for 3 hours, all of a sudden somebody comes in with a clipboard and asks some questions and then walks out. And there's no development in that kind of situation. There's nobody who you trust, who you can say, I feel frightened here, or, you know, I would, can I go to it? Can I, you know, whatever it is that they want, that they're feeling would help them at that moment. They feel at the mercy of the system, and they often leave. I mean, people leave emergency rooms or try to get out of emergency rooms, and then they're confronted with security. And so that creates a real immediate tension. If somebody feels unsafe because of somebody, they're with other people who are behaving in a way that makes them nervous, and they try to leave, and they've gone in for a mental health call, a lot of times they won't be allowed to leave right away. And then it becomes a very tense situation that could have been cut off by providing a private area for the person.
Thank you so much for addressing that and talking about what we could be doing to improve the quality of the environment in the Psych ER. So we're almost running out of time. I see a question that keeps coming up recurringly, and I think I might be the best person to answer this one. So I might take it, but if anybody else has anything to add, please do. And then if we have any time, I'll sneak in another question if that's okay. So the question is, why do we see less comfort in the Hispanic or Latinx and Black communities to discuss mental illness? So various folks have actually brought up issues of diversity in our comments and chats, and I want to just say I see you as a Black and Latina woman. Like, I see you and I hear you. Thank you so much for bringing this and raising it. There are so many various reasons why our communities don't feel comfortable. Like, universally, there is a stigma with mental health in discussing it across all cultures, right? But when you identify under the BIPOC umbrella, specifically, like, I'm thinking in the Black, Afro-Caribbean, and African-American communities, there are tropes that have been assigned to us, you know, the strong Black woman stereotype or archetype that we have to live up to, or it's put onto us, we internalize it, and it's oppression, right? It's internalized oppression that we feel that we can't talk openly about these things because then we're seen as weak. And we have historically for 200 and hundreds of years been trying by an oppressor to be made as weak, right? When we in actuality are equal people to any other race or ethnicity. So I want to say that it comes from a history of oppression. It comes from visibility. You know, personally, I'm going to share this. I have moved all over. I've moved to I'm from Queens and Brooklyn. I've lived in East Harlem. I've lived in the Bronx. And just because I've had such bad experiences not having another person of color as a provider, I still travel to Flatbush to my one therapist that we have been rocking together for a while, and she just sees me as a queer woman and as a Black woman and as a Latina. She sees all of my identities, and I don't feel like I have to explain myself further or explain parts of my culture that might be seen as confusing or more attributions to my mental health condition, right? But I won't go into too much detail on this. I just want to say that it comes from a history of oppression. We lack cultural competency. We lack enough providers of color. We lack linguistically appropriate care. And then we have an extra financial barrier, not saying that everyone who identifies as BIPOC it has of lesser means. We know that that is not true. Income is not directly associated with race or ethnicity. However, we do have a large majority of New York City, unfortunately, that are undocumented and identify as BIPOC, or even trans folks and non-binary folks, and they also are uninsured. And it's really important. And if they are insured, then maybe the providers in their area don't even take in-network, right? These are all the structural barriers to care that leads people in our communities and in all communities to end up in the Psych ER. There are levels of care. If you don't have the basic at the primary level for mental health care, then of course your symptoms will be exacerbated. And so because some of us don't even have access, the financial means to pay for it, why would we even talk about it? You know? So we need to do more. Our city needs to be doing more to do work in, invest in workforce development. We need to make sure that licensed mental health counselors have the ability to diagnose because they have the same amount of education as social workers who can bill for their diagnoses. And by opening that up, you'll see that a lot of licensed mental health counselors and licensed counselors are actually people of color that could be serving our communities and getting paid for the work that they do. But now I'm gonna hop off of my soapbox because I really want to-
I'll just jump in one quick, just to acknowledge the fact that, you know, of the 5 out of the 7 participating organizations were synagogues. It's, I don't have anything to say necessarily.
Oh no, you're muted, go ahead.
Yeah, one of the things that we as a group did not do was to make sure that, oh, look, we don't really have much. People have talked about the lack of diversity in the panel, but also I think you have to talk about the lack of diversity in the group that was surveyed as well. So because I think the participants, as I said, were 5 synagogues in Manhattan, which focused a lot of the answers on Manhattan, and didn't have the diversity that we should have worked for. Pandemic got in the way, other things got in the way, but we need to, Ray, I think, John, we need to redo this and really look to recruit other folks to bring the questioners to their communities.
Thank you so much, Rabbi. So I know we're at time. I don't want to keep anyone over, so I just want to let you know what's next, okay? We don't have a date yet, but I want you to stay tuned to NAMI emails because we will have a follow-up panelist discussion. Specifically, we are trying to work with folks who are part of the mental health care interface model across the city. So community-based providers, hospitals, private providers, we want to hear from you. If you're interested, if you know hospital reps, if you have connections, please do email me at advocacy@NAMI-NYC.org. We want to be connected with these hospitals that we have visited and have had these experiences. We want to work together for change. And we want to hear their perspective as well. So that's what's next. And also you can get involved in the various ways that I mentioned before. We'll send out the survey. Caitlin, you can put it one more time in the chat. The survey is now live for folks who have had experiences with the Psych ER. We would like to hear from you and hear your stories. So it's not the same survey that we were talking about throughout this panel, but it is a survey to collect stories from you and see if there's any way we can amplify these for change. And we always have upcoming rallies and campaigns and other ways to get involved, but also check out Manhattan Together and all of the different congregations that we mentioned earlier. We'll make sure to list them out in the follow-up email. Check them out. They're wonderful people. They're social justice warriors that came together to try to really hear for and change this psychiatric care experience. And as always, you can contact our helpline for support. This is our number and our email. So thank you all and be well. Thank you all. And thank you to the panelists, to my wonderful interpreters, Jane and Janine, ASL interpreters, and Andres, You're awesome. I always love working with you. And Rabbi Siebert, Alan Doyle, Ray Schwartz, John D Natalie, and Joanne Kennedy. Thank you all for being panelists today.
And thank you, Kimberly.
Oh,
Yes,
you.
thank you, Kimberly.
Great
Thank you,
job,
Kimberly.
Kimberly.
Excellent job. Thank you for bringing us all together like this.
I love it. I love collaborating. Thank you all.
Be well.
Okay, bye.
Good night, everybody.
Good
Good
night.
night.
Night.